Rickets and scurvy. Now, starting with the rickets, it is the defect in the mineralization of the growing long bones. So, rickets is defect in the mineralization of growing long bones. Now, coming to the etiology of rickets, we have got vitamin D deficiency. The most common etiology of rickets in children is nutritional rickets. So, nutritional vitamin deficiency is the most common cause of rickets. We can have a congenital deficiency of vitamin D as well. There can be malabsorption and liver disease. And we'll read about the vitamin D dependent rickets type 1 and type 2. Vitamin D dependent rickets type 1 is basically because of 1 alpha hydroxylase deficiency, whereas vitamin D dependent rickets type 2 is because of resistance of receptors to the action of 125 hydroxylase vitamin D3, which is the active form. And definitely we can have renal failure while the serum phosphate will be high. We'll see the algorithms. Just for clarity, let us remember the most common cause of rickets is nutritional, and we have got vitamin D dependent rickets type 1 and type 2. Vitamin D dependent rickets type 1 is because of 1 alpha hydroxylase deficiency, whereas vitamin D dependent rickets type 2 is because of the resistance of receptors to the action of 125 hydroxylase vitamin D3. Okay. So what about the renal losses? In case of renal losses, we have the hypophosphatemic rickets. Hypophosphatemic rickets is because of the PHEX gene. We can have some tumor-induced rickets, the McCune-Albright syndrome, and the Fanconi disease, Dent disease, and distal RTA. So just let us look very briefly, how can we differentiate between vitamin D deficiency and vitamin C deficiency? So vitamin D deficiency is nothing but rickets, whereas vitamin C deficiency is scurvy. So in vitamin D deficiency, as I said, is the defect in the mineralization of the growing long bones. So what happens? The child is very much irritable in case of scurvy. But in case of rickets, the child is not much irritable. We'll have rachitic rosary in rickets and scorbutic rosary in case of scurvy. Whereas the radiological signs are different in both. In rickets, we'll get cupping, splaying, and the fraying. We'll explain what is cupping, what is fraying, and splaying later on. Whereas in scurvy, we'll get some features like white line of wrinkle, the Pelkin spar, Wingberger ring sign of the epiphysis, and the subperiosteal hemorrhage. Coming to the clinical features of rickets. The first clinical sign of rickets is craniotapes. So this is the first clinical sign, or you can say it is the earliest clinical sign. In case of rickets, it is as early as 6 months. We'll also have delayed closure of the fontanelles. There will be frontal bossing, dental hypoplasia, white sutural lines, and there is going to be pectus carinatum and rachitic rosary. It is very important that we differentiate between rachitic rosary and scorbutic rosary. Rachitic rosary is because of rickets, whereas scorbutic rosary is because of scurvy. In case of rachitic rosary, because of rickets, just remember R for R. It is rounded, smooth, and non-tender, that is painless. Whereas, if I have to talk about the scorbutic rosary, S for S, it is sharp, angulated, and tender.